Hello, this is Mrs. Alston, and today we will be talking about the intravenous expiratory urography, or IVU. This is the patient preparation and positioning lecture. So the purpose of the IVU and IVP was the older term intravenous pyelogram, but the IVU is what is most commonly known as. The purpose of this is to visualize the collecting portion of the urinary system, to assess the functional ability of the kidneys, and to evaluate the urinary system for any pathologies or anatomical anomalies. So looking at your IVU clinical indications, you want to refer to page 547 to 548, the abdominal or pelvic masses, renal or ureteral calculi, kidney trauma, flank pain, hematuria, renal hypertension, renal failure, urinary tract infection or UTI, hypersensitivity to iodine, anuria, multiple myeloma, diabetes, renal disease, CHF, and pheochromocytoma. Also make sure that you're aware of sickle cell anemia crisis. Now for the IVU patient prep, you want to refer to page 551. The preparation consists of a light evening meal, a cathartic the day before, enemas until clear in the morning, and NPO after midnight. It is also recommended that children drink carbonated beverage after injection to distend their stomach and help push the intestinal loops down out of the way and act as a window through which to visualize the kidneys. Children usually do not receive a bowel prep. All clothing should be removed with your patient, and the patient should void prior to the exam beginning for two reasons. One, if the bladder is too filled, it could rupture, especially if compression paddle is used. And this is not common, but if it does get too filled, the patient will usually let you know, or involuntary incontinence will occur. And the second reason is because urine already present in the bladder will dilute the contrast accumulating there. And that's the most common reason for having the patient void before you start the exam. As far as your room preparation is concerned, you need to have the correct type and amount of contrast media. You need to have an empty container of the contrast. You need to select the needles and the tubing along with the alcohol sponges. You need to have a tourniquet, a support for the elbow, an emesis basin, lead markers, the emergency cart with epinephrine available, towels, cold and hot if necessary, your ureteric compression device, and obviously your shielding. The basic routine overheads for an IVU are going to be a Scout KUB. Then after the injection, you're going to note the time of the beginning of the injection. Your routine filming is going to be within 1 minute after the injection, and that's going to be your nephrogram or your dedicated kidney shot. Your 5-minute AP supine is going to be a 14x17 full KUB. Your 15-minute is going to be an AP supine, 14x17 full KUB. Your 20-minute are going to be your posterior obliques, both LPO and RPO, 14x17 KUB. And then a post void can either be done prone or erect, 14x17 KUB. So the required Scout is the same as your abdominal film or your KUB, and it should include the kidneys, the ureters, and the bladder. The Scout is used to be checked by the radiologist prior to the injection, and there are a couple of reasons why we do this. One of them is to identify and locate any abnormal calcifications that are already in the abdominal area. 2, to identify any unusual shadows. 3, to identify unsuspected aortic aneurysms or other abdominal masses. 4, to check for adequate patient preparation. And 5, to determine whether exposure factors were acceptable. For the technologist's responsibilities, we need to check the films and ensure that there is no motion. Check for positioning to make sure the upper poles of both kidneys and the symphysis pubis are visualized. Check the collimation to make sure it's adequate. After your Scouts are performed, you want to recheck everything with the radiologist prior to the injection, and make sure you note the starting time of the injection and the length of the injection. And the timing of the injection takes anywhere from usually 30 seconds to 1 minute to complete. So that first image should be taken within the 1 minute mark. So for the IVU, the reason why we do this is to visualize the collecting portion of the urinary system and to assess the functional ability of the kidneys or the nephron unit. It tests the function of the kidneys because the contrast media is removed from the bloodstream and excreted by the normal kidney. The physiological method is the IVU. So we're not only looking at the form but also the function of the urinary system. The IVU procedure requires that we follow a first image immediately upon injection or within 1 minute of injection to capture the early stages of the collecting system, and this is usually done of the kidneys, so it's called a dedicated kidney shot. And then, as I said, you're going to have your 5 minute, which is the full KUB, the 10 or 15 minute, which is a full KUB. Your 20 minutes are going to be your obliques, and your post-void is going to be either done in a prone PA or an erect AP. This is an image of a 10-minute IVU. After the full injection of contrast media, radiographs will be taken at specific time intervals depending on your department, and there are going to be many variations based on the site's SOP, so make sure that you are familiar with what the radiologists have designated as their common protocol. There are 2 ways to keep the contrast in the kidneys longer, so if they would like to retain the amount of contrast in the kidneys as long as possible, because remember, the kidneys are just going to automatically drain whatever it feels the body does not need. So if the radiologist wants to keep the contrast up in the kidney area a little bit longer, they can either place the patient in a Trendelenburg position, because in this position the contrast will tend to stay in the pelvical calyce area longer because the kidneys will be lower in the position than the ureters will be. And then the other technique is going to be known as the compression technique. So utilizing the compression technique, this is where a belt will be placed around the patient's waist with inflatable balloons over the lower abdominal at the outer edges of the pelvic brim, and the pressure is applied over the distal ureters at the pelvic brim. This helps to retain the contrast in the kidneys longer. So kind of like your inflator cuff on your barium enema, you will place those inflator cuffs on the outer portion of the pelvic brim, and then you will use the balloon to help blow those inflator cuffs up, and then you have the compression band that will push those inflatable balloons down on the distal end of the ureters, which will help retain the contrast in the kidneys a little bit longer. Now, there are some contraindications for using the compression. They would be if the patient had possible ureteric stones, if they had abdominal masses, if they had an aortic aneurysm, if they had recent abdominal surgery, if they had severe abdominal pain, or if they had acute abdominal trauma. You would not want to use the compression paddles. Instead, I would place the patient in a Trendelenburg position and let gravity do its job. So there are variations to the routine. You can have a spill radiography, which is done in the supine position, and this is upon the release of the ureteric compression. You would release it and then take an exposure immediately, and that should help to fill the ureters with the contrast that has been remaining up in the kidneys. You can have delayed radiographs, which are ordered if excretion of the contrast is low, or you can have an erect bladder, which helps to demonstrate possible enlarged prostate or a prolapse of the bladder. So when you're performing your obliques, it's going to be done on a 14x17, 40 or 48 inch SID. The patient is going to be semi-supine with a 30-degree obliquity. Now remember, we talked about the position of the kidneys in our anatomy PowerPoint, and because the kidneys lie 30 degrees from the horizontal plane, you have to rotate the patient up 30 degrees to make the kidney parallel to the IR. So what we're best demonstrating here is the upsided kidney parallel to the IR and the downsided ureter anterior to the vertebral spine. So for this RPO, we're going to best demonstrate the left kidney parallel to the IR with the right ureter anterior to the vertebral spine. So here is just a radiograph and the diagram of the elevated left kidney is going to be parallel to the IR. and the right ureter is going to be best demonstrated anterior to the vertebral spine. For our AP erect, this is typically performed after the procedure is complete. This could be your post-void. The patient will use the restroom and then you'll perform this x-ray. It's going to be a 14 by 17 lengthwise. Patient's going to be erect up against the wall bucky. You're going to center at the iliac crest and mid-sagittal plane. Sometimes you may have to center a little bit lower depending on the patient because the kidneys will drop about an inch as a normal drop because of gravity in the patient standing. We'll perform all these images on expiration because they are considered abdominal films. And if the kidney drops lower than the normal 1 inch, then that's called nephroptosis, which means it is dropping further than what it should normally drop. It can also look for a prolapse of the bladder, enlarged prostate, and or the entire urinary system in this erect position. So then you'd want to mark, all of your images are going to be timed, so you're going to mark from the initial injection time. You're going to have a 5-minute, a 1-minute, 10-minute, 50-minute, 20-minute, and your post-void, they should have the time and post-void on there as well. So like the small bowel, the IVU is a timed procedure. Here is your alternative, the PA, which is going to be done at a 40 or 48 inch SID, still at the iliac crest and mid-sagittal plane. And then if you happen to clip the bladder, if you can't get the kidneys and the bladder on one image, you can go back and get the bladder shot. This will be done on a 10 by 12 or 11 by 14. The patient's going to be supine. Put the CR about 2 inches superior from the symphysis pubis with a 10 to 15 degree caudal angle, and that is going to project the symphysis pubis below the bladder. 40 inch SID, done on expiration, and then just collimate down to the urinary bladder itself. Now we're going to look at some urinary pathologies. So a calculus of the distal left ureter, they are small triangular shaped calculus in the left distal ureter, blocking flow of urine and the contrast media, and the arrow is just demonstrating where that stone is. This is a calculus of the right ureter. Unusually large calculus in the right ureter is being outlined by the white arrow, and so that big white circle is a calculus or a kidney stone. There's a large stone in the bladder, so you can see it outlined as the white there. That is a bladder stone. You can have dual renal pelvis and cystitis or a filling defect. So the radiograph A, the one on your left-hand side, is a bilateral dual renal pelvis and ureter. So sometimes patients can have 2 renal pelvis on one kidney and 2 ureters. This would be an incidental finding. And the image on the right is going to be cystitis or inflammation of the bladder. It shows a regular lobulated filling defects at the base of the bladder. This is a staghorn kidney. So that just is a large kidney stone outlined in the white arrows. So that entire white area in the left kidney, that is known as a staghorn because of its large appearance, and it kind of looks like a horn coming off of an animal. This is going to be cancer of the prostate with metastases to the pelvic and spine, so that's why the spine looks so white and kind of cotton ball appearance. Along with the pelvic area, you see those blotches of white and black and grays. That is metastatic disease. So when you're thinking about the urinary system, consider these questions. What are the parts of the urinary system? Describe the anatomy of the kidney. Where do the parts of the urinary system lie within the human body? What are the various radiographic examinations of the urinary system? What are the 3 stages of reactions to contrast media in the systems of each? What are the different types of contrast? What is the preparation, room, and patient prep for the urinary exam? What is the function of the urinary system? And what are the normal BUN and creatinine levels? So this concludes the patient prep and positioning portion of the IVU.